Good afternoon, everybody. We'd like to get started now. If you all can take a seat. And feel free to move into the center if you'd like to. You're kind of far away. So thanks for joining us. This is Symposium 3, entitled Pro-Con Care Plan Compliant. My name is Sue Gray. I'm the Adult Program Coordinator at the Medical University in Charleston, South Carolina. And my co-host, Christina.
Hi, I'm Christina Robinson. I am president and founder of Halite Solutions Group. I started this nonprofit organization combining my career experience in community health and a late CF diagnosis. We foster collaborations, connections, and communication across the CF landscape.
Thank you. So, as most of you know, the landscape of CF care has been impacted over the last few years, first by the global pandemic, and then by approval of the highly effective modulator therapy, for which the majority of those with CF have been prescribed. Those in the CF community, from care team members to those living with CF, have recognized that following the recommended CF care model has been a challenge because of all of these changes. So, and as a result of these changes, the CF Foundation has convened a committee to examine the current data and best practices to determine recommendations for the care of CF moving forward into the age of highly effective modulator therapy. So today we're going to take a deeper dive looking at some of these challenges. Dr. Rebecca Flowers-Brown, who is co-chair for the new Model of Care Committee, will provide a background on the evolution of the CF care model. Then Dr. Whitney Brown will share data from the registry that will show what's happening with data at the national level. And then finally, we're really excited to have a panel discussion with 3 members of the community, all of whom have CF. And they're going to join us and discuss their experience with the care model and also the effect of some of these changes on their emotional wellness. So we're hoping for a very robust discussion. Encourage you to ask questions. You can either get up and use a mic to ask a question, or you can find this third symposium in the app and just click on the Q&A, and we'll try very hard to get to all the questions. Realize I'm a little tech challenged, so give me a break on that. But other than that, we're going to kind of go back and forth with questions, and we'll have a speaker talk for 15 minutes and then 5 minutes question and answer after each, and then also more question and answer time after our panel discussion. So with that, Christina?
I'm pleased to introduce our first speaker, Dr. Rebecca Flowers-Brown. Dr. Brown is a pediatric pulmonologist and the center director at the CF Center at Vanderbilt University in Nashville, Tennessee. She is also the co-chair of the new CF Model of Care Committee, dedicated to shaping the future of CF treatment by studying current practices and data, especially in the era of highly effective modulators. Please welcome Dr. Rebecca Flowers-Brown.
Thank you guys for inviting me to be part of this symposium. And what an exciting time in CF to be able to talk about the possibility of changing our model of care due to advancements in therapies and improvements in outcomes. So I'm going to start by setting the stage and discuss where we were with CF care, where we are currently, and where we are going. I have no relationships to disclose related to this presentation. So today I'm going to provide an overview of what led to the development of the current clinical practice guidelines for CF care, discuss changes that have impacted the CF clinical practices in recent years, and provide an understanding of our next steps forward to adjust the CF model of care to meet the newer needs of people with CF in the United States. So where were we? The initial clinical practice guidelines for cystic fibrosis care were completed in 1997. You can see on the right side of the screen that many people across the country contributed to these initial guidelines, which were included in the white binder. This white binder can still be found on some CF providers' bookshelves to this day. These guidelines have been updated throughout the years through additional evidence-based guideline development, as well as consensus statements, which have been published in the interim. For example, the guidelines for CF-related diabetes, which were published several years ago. These clinical practice guidelines set up the traditional model of care, which has continued to be used in CF to this day. This included clinic appointments 4 times a year with 4 sputum cultures and at least 2 pulmonary function tests a year. In addition, these guidelines set up the CF specialized care team, which is shown in the illustration on the right, with your core group of CF team members. And then throughout the years, additional members have been recommended, such as physical therapy, mental health coordinators, and a pharmacist. The recommended treatments for people to complete as part of the home regimen for CF were described in these guidelines as well, but I will not be touching on those today. These guidelines and recommendations worked. We know this because outcomes for CF improved throughout the years. Processes were standardized, and these guidelines allowed us to know that if you moved from one CF center to another CF center, your care is going to follow these standardized guidelines. In addition, quality improvement processes were shared and data outcomes were transparent, which helped to elevate the care of CF patients throughout the U.S. People with CF seen by specialized CF teams have improved outcomes compared to those not seen by a CF team. We have a few studies which have suggested the importance of a CF specialist team involvement in the care of people with CF. So I want to take the opportunity to describe some of these today. This initial study that I'm going to talk about is actually from the UK, but the findings are likely applicable to specialized CF care in the US as well. As you can see in the chart, we have columns that indicate people who have received both pediatric and adult CF specialized care. The middle column represents people who received adult CF care but no pediatric CF care. And on the far right, people received neither pediatric nor adult CF care. That first row is lung function, which is noted as the percent predicted FEV1. And as you can see, lung function is higher in the people who received care from a CF care center. There appears to also be a dose effect with a higher lung function for those who are followed by a CF care center during both pediatric and adult care, compared to those who were only followed by a CF care center during their adult years. Similar improvements were noted for nutritional outcomes, the second row, which includes the body mass index measurements, as well as changes in chest x-rays, noted by the chest x-ray film score, where a higher score indicates a more severe level of disease. These data are from 1998, and so we recognize that changes have occurred in CF since that time. This next study includes more recent data looking at outcomes after lung transplant for people with CF who received a transplant at a center that was associated with an accredited CF care center in the US versus people who received it at a center that was not associated with an accredited CF care center. For this study, data were evaluated within the Scientific Registry of Transplant Recipients and included adults with CF who received a lung transplant for the first time between the years 2005 and 2018. This figure shows the time to graft failure. After receiving a lung transplant, your hope is that your lungs are going to last as long as possible. And so in a chart like this, your desired outcome is going to be higher lines, which would indicate that your lung transplant lasted longer and it took you longer to have graft failure. People who received a lung transplant at a non-CF care center, which is the blue line, had earlier graft failure than those who received one at a CF care center, which is the red line. The median predicted survival for people transplanted at an accredited CF care center was 7.8 years, in comparison to 4.4 years for those transplanted at a transplant center that did not have an associated accredited CF care center. This figure from the same study reveals the risk of death or retransplantation after lung transplant. For this chart, we would like the numbers to be lower because you want to have a lower risk for death or retransplantation. As you can see, those transplanted at a non-CF care center, the blue line, have a higher risk of death or retransplantation than those who received lung transplant at a CF care center, the red line. In fact, adults with CF who received a lung transplant at a hospital with an associated CF care center had a 33% reduction in risk of death or retransplantation compared to those who received a lung transplant without an associated CF care center. In addition, a recently published study demonstrated the effects of gaps in CF specialized center care. Data from people in the US with CF who were entered into the CF Foundation patient registry from 2004 to 2016 were included in this analysis. Discontinuous care was described as a gap in care at an accredited CF center for at least 12 months. During that time period, 35% of people had at least a 12-month gap in care at a CF specialized care center. Now, this has a lot of graphs on it, so bear with me for a second. These graphs reveal the percent predicted FEV1, which is a measurement of lung function, in people with continuous care, which is the solid line, compared to those with discontinuous care, shown with the dotted line. That first panel, panel A, has a little dotted box in it, and that box has been amplified and made bigger into panel B. So panel A has all ages at encounter, and panel B has ages 15 to 25 years old. This is further subdivided into panels C, where people were aged 15 to 25 years of age and had 2 copies of Delta F508, and panel D, where they are 15 to 25 years of age and have just 1 copy of Delta F508. As you can see, those with discontinuous care, those with the dotted line, had lower lung function than those with continuous care, the solid line, in all of those panels from 15 to 25 years of age. In addition, sensitivity analysis revealed that there may be a dose response, meaning that the longer a person is away from CF specialized care, the bigger the difference in lung function compared to those who have continuous care. As you can see from this chart, which outlines 6-month gaps, 12-month gaps, and 18-month gaps, the decline in lung function is progressive the longer you're away from CF care. These data are from before the pandemic and before elexacaftor, tezacaftor, ivacaftor approval. However, they make a strong case for ongoing CF specialized care, which will need to be considered as we move forward with discussions about a new model of CF care. So now we can move on to where we are. As you all know, we have had some changes in the CF world over the past few years. First of all, elexacaftor, tezacaftor, ivacaftor, or ETI, was approved in October 2019, initially for people 12 years of age and older. This approval has now been extended all the way down to 2 years of age. In addition, the pandemic followed on the heels of ETI approval starting in early 2020. The COVID pandemic allowed some slower moving advancements in medical technology, including telehealth and remote monitoring, to advance quite a bit more quickly as the necessity for remote care was amplified and improvements in this technology were needed in real time. The care we provided during the pandemic shifted from in-person clinic encounters, shown here in blue, to telehealth, which is shown in red. As you can see, there was a sharp decline in in-person appointments and a sharp rise in telehealth appointments early in 2020. What is interesting is that even as the pandemic has lessened, the in-person clinic encounter volume has not increased back to the pre-pandemic volumes, and a decent proportion of visits continue to be provided through telehealth encounters. This is another way to look at care over the past few years. In this graph, the green lines represent pediatric patients aged 7 to 17 years old, and the blue lines represent adults. The dotted lines indicate people who really met the minimum requirements for coming in, so they had 1 visit, 1 culture, and 1 lung function per year. and the solid lines indicate care closer to the current recommended model of care of at least 4 visits, 1 culture, and 1 lung function a year. You will note that is not quite the current guidelines for care, but it is a modified one which we adapted after the pandemic. As you can see, those meeting the recommended guidelines for care in the US for the solid lines have not recovered back to pre-pandemic levels of care. During the same time where we've had less frequent encounters with our patients, we have seen marked improvements in lung function. This graph includes data for adult patients with CF from the CF Foundation Patient Registry. As you can see, both the mean and median lung function have improved for adults with CF over the past several years from 2019 to 2022. The red line here represents the median lung function, and the blue line represents the mean or average lung function. In addition to just having this rise in lung function, the difference between the median value and the mean or average value of lung function has increased over time, which suggests that the number of individuals with lung function that's higher than the average value with CF has also increased over time. So a really good story. So now that we've talked about the initial clinical practice guidelines and we've talked a little bit about the changes that have happened, we need to talk about what's in our future. So where are we going? As we've already mentioned, there have been improvements in outcomes and overall health of people with CF. A lot of this is due to highly effective modulator therapy. However, also over time, we've seen patients pre-highly effective modulator therapy have improvements in their outcomes, in part because our care delivery and treatment have improved over time. We also had rapid advancements in remote delivery of healthcare, remote monitoring, and asynchronous care during the pandemic. And so all these changes allow us to rethink the CF model of care to meet the current needs of people with CF. And so a committee has been developed to look into potential changes in the current CF model of care. The red flags on this map here represent the members of this committee who come from across the United States. The committee convened for a kickoff meeting in August 2023, and it includes representation from the multiple disciplines that are involved in the care of CF, as well as both adult patients with CF and parents of children with CF. This committee is asking questions about current and possible future model of care for CF, including who should be part of the CF care team in the new model of care? How many people are needed for each role? And do we need to add people, for example, pharmacists, genetic counselors, or even a geriatrician given the aging CF patient population? What an excellent question we have the opportunity to ask about an aging patient population. What frequency of visits is ideal, and how many cultures and pulmonary function testing is needed to maintain the health of people with CF while minimizing the burden of living with CF? And in what settings can routine or sick care be performed virtually, and what monitoring can be performed remotely? And probably most importantly is what data do we have available to make these recommendations and track outcomes after these changes are made to the model of care? Do we need to change the data that we're collecting to ensure that we can understand where the recommendations were beneficial and right on target, or which recommendations may have missed the mark? Of note, we will not be addressing treatments as these are already covered by other guidelines, although we imagine that these recommendations may adjust over time through conversations between individuals with cystic fibrosis and their care team members based on their unique healthcare needs. The other Dr. Brown, Dr. Whitney Brown, is going to be going through some of the registry data, so you'll get a sense of what data we already have available to track outcomes. As you have hopefully already seen at other sessions, a survey is available for CF team members to provide feedback during changes to the CF model of care. These results, along with survey results from people with CF and their families, will help guide CF care to better meet the needs of people with CF. So please feel free to scan the QR code using your phone's camera to complete this survey now or later. We do have some time for questions right now. And as we address the questions, I'm going to put back up the QR code because we really do want your input as we move forward in this process. Thank you.
do have a question, just curiosity. When you were talking about the gap in care of a year, I can't remember what was the cause of the gap in care? Was there any indication of that?
I don't think we know the cause of the gaps in the care because this was data from the patient registry, and we don't currently ask why people aren't coming to CF care. That's a good question.
Any other questions? Thank you.
Okay. Thank you.
Okay. Thanks, Rebecca. And now I would like to introduce our second Dr. Brown, Dr. Whitney Brown. Dr. Brown is the Senior Director of Clinical Affairs at the CF Foundation, and she also continues to practice at the Inova Fairfax Adult CF Program in Falls Church, Virginia. Dr. Brown?
Okay, thank you for the invitation to speak. And it's really my pleasure to speak on behalf of our department at the CF Foundation, and in particular, the patient registry team. Oh boy, we thought this might happen. There's a problem with the advancer.
You have to be forceful.
Click
Okay,
forward once
click
and then
once.
it'll work.
Okay, I have no disclosures. There we go, there we go. So we heard from Dr. Flowers Brown about the pivotal events of the last few years, and we know them personally from living through them. And there's clearly a changing landscape in CF. And based on CF Foundation patient registry data from 2022, we will review trends in utilization over time and differences by age and modulator status. So this figure gives us an overall impression of CF care utilization over the last several years. And on the y-axis, you can see the number of encounters entered into the registry. Blue represents in-person clinic visits. Gray represents telehealth, and before the pandemic, it could have been audio visits, and then also includes video visits. And then red represents hospitalizations. And what we can see overall is that there's been a 30% decrease from 2019 compared to 2022 in terms of total clinical encounters. Most notably, a decrease in in-person visits on the blue bars, but also, thankfully, about a 50% reduction in hospitalizations. And then, of course, telehealth initially expanded, that's the gray area, in 2020, and then has contracted a little bit, but it certainly remains in play with about 21% of visits last year being delivered via telehealth. So that was on the overall patient registry population level, but what about the individual level? So in this figure, we see the average number of encounters in the registry per individual. And there's no hospitalizations here. This is just outpatient visits in person or telehealth. The red depicts in-person visits in this figure, and the blue represents telehealth visits. And these visits could be routine visits or they could be sick visits. And we can see since 2019 a very similar pattern, a little less subtle, but a gradual decline in outpatient visits from almost about 5 a year prior to the pandemic and Trikafta to a little under 4 a year on average per individual last year. And we can see in that red that there has been a tick up since 2020 in in-person visits, but certainly not a return back to where we were. And of course, the blue is still there, although a little bit smaller, but indicating that telehealth is still playing a role. We know at visits, many things happen, and one of those things, or two of those things, are PFTs and respiratory cultures. This graph shows us the trend in the average number of PFTs in blue and average number of respiratory cultures in orange for each individual over the last approximately 12, 13 years. And they were pretty steady, as you can see, but a very sharp decrease in 2020, not surprisingly. A little bit of an increase back up in 2021, but really stable in 2022. So overall, leaving us with a significant decline in both PFT and respiratory culture data entered into the registry. Another critically important component of CF care is evaluation by the multidisciplinary team. And this figure shows us the percentage of individuals in the registry who are evaluated by each of the team members every calendar year. And up top, we see physical therapy, respiratory therapy or physical therapy doing the RT evaluation, dietitian, and social worker. And you can see, dating all the way back to 2012, very high levels of seeing these team members, approximately 85, 90% of individuals being seen by these team members at least once a year. A little bit of a decrease in 2020, but really nice return to that 85, 90% range over the last few years. And bottom in green, we can see a steady rise in the number of percentage of individuals being evaluated by a pharmacist each year. So we examined trends in the CF population at large, but I would argue that the CF population can be considered in many different ways. So if we examine trends based on age, first let's look at age. And we can see this figure shows us that the adult population continues to grow. And in the blue segment of the figure here, we can see almost comprising 60% of all individuals in the registry now. And this is a histogram that shows us how many individuals are at each particular age in the registry. And overall, still a young population. You can see that the bump is shifted or it's skewed to the left. However, there are growing numbers of aging adults out to the right, and aging adults may have different needs. This figure examines differences in outpatient visits like we just saw, but breaking it down between pediatric and adult. And again, average visits per year is on the y-axis and listed at the top of each bar. Overall, the first observation we can make is that children have more visits compared to adults, and that has been the case for a while. Both groups have had a decrease in their average number of visits over the last 7 years, and you can see 18% for adults and 15% for kids. And again, most of that change accelerated starting in 2019. In-person visits on the left are in red for adults and green on the right for children. And telehealth, conversely, blue for adults and gray for children. And we can see at the end of last year, about 28% of visits for adults were via telehealth, but only 16% for children. So we can see that this highlights two differences in this population. One, children have more CF visits than adults. And two, the percentage of telehealth is greater among adults and kids. One of the components that we spoke about that happens at in-person visits is the collection of respiratory cultures. And here we can see that among children, this focuses on children, the average number of cultures has gone down about 20% since 2019. In addition to that, not just the total number of cultures is down, but there's been a change in the type of cultures that's being submitted. Increasingly more oral pharyngeal or throat swabs, which is the green segment, compared to sputum cultures, red, over the last few years. And this is likely due to ETI and the fact that many individuals can no longer produce or are producing less sputum for culture. And as we know currently, OP swabs are generally performed in CF clinic, but over time, we may need to consider alternative ways to do swabs at home, in the pediatrician office, et cetera, to allow for continued quarterly testing if clinic visits continue to decrease. And this is particularly important, we know, for the initial detection and eradication of Pseudomonas. And here we see the correlate on the adult side. There's been a 30% drop in respiratory cultures since 2019. And this trend of increasing oral pharyngeal cultures is even more dramatic in adults, and that's in green. Likewise, the sputum cultures in red, the percentage of cultures being done by sputum has gone down. And specifically, if we hone in on 2019, 80% of the cultures were sputum cultures in 2019, and only 53% of cultures submitted were sputum cultures last year. And this results in a greater reliance of OP cultures for adults. And again, because OP cultures are generally done at the time of in-person clinic visits, less visits usually results in less cultures. So we covered age. How about modulator status and thinking of different segments of the population? Currently, about 90% of the CF population is eligible for a modulator. And in 2022, about 82% of eligible individuals were prescribed a modulator. On the left, we see that same age histogram in gray that we showed earlier. The blue on top of that represents individuals that are eligible to take a modulator. And superimposed on that in red are those who are actively being prescribed a modulator as of their last visit in 2022. So while the majority of individuals, particularly over the age of 12, are taking modulators, it's important to remember that it does not represent everyone. And for those who are not taking modulators because they're not eligible or they're not tolerant of them, care needs may really not have changed much over the last several years. This year in the annual data report that's being released this week, there is a new chapter that breaks down data by modulator status. And I'm going to give you a preview of that. And 3 groups have emerged in the analysis. First is the modulator group. This is the group on the left. And for the purposes of this figure, these are individuals that were consistently prescribed Kalydeco or Trikafta since 2020, not patients that started and stopped consistently prescribed. And we can see that this group has experienced a 7% improvement in FEV1 since 2018, with that big step up again happening in the pivotal year between 2019 and 2020. The second group is the modulator ineligible group based on gene mutations. And they've experienced an 8% decline during the same time period in FEV1. And then the last group is a group that is eligible but never prescribed modulators during this time period and excludes people that have had a lung transplant. And this group, interestingly, on the whole, looks like it has significantly better lung function. You can see the FEV1 at the start of the time period, about 90% predicted. And perhaps this group is a unique group, and it actually is very small, under 1,000 people nationally, but perhaps they have declined taking a modulator due to preserved lung health, a type of selection bias, shall we say. But on the whole, they look like they've had only a 2% loss in FEV1 over this time period, but if you compare to their peers taking a modulator who had a 7% gain, maybe there's a bit of a signal there. Here are the same 3 groups, but now we're going to look at pulmonary exacerbations, and these are requiring IV antibiotics. And what we can see for all 3 groups is that there was a drop in exacerbations in 2020 and in 2021, likely, of course, related to masking and social distancing with the pandemic. However, in 2022, you can see in the first group that there continues to be significantly less exacerbations for those on modulators. For the modulator ineligible in the middle, despite the transient decline in pulmonary exacerbations for those 2 years, there was an uptick last year, and overall an increase of 6% when we look back compared to 2018. And then lastly, there was a modest group for those who were eligible but not taking, a modest decrease for those who were eligible but not taking modulators compared to 2018. So now that we've looked at differences between these 3 groups in terms of lung function and pulmonary exacerbations, we can see if that translates into different clinic attendance. And so in this figure, we are looking at a combination of either a telehealth visit or an in-person visit. And our same 3 groups, so for the modulator group on the left, we see a steady step down in total outpatient visits with an average of about 3.5 visits per individual in 2022. In the middle group, our modulator ineligible group, there has been a little bit of up and down wiggle over the last few years in terms of numbers of visits, but last year it looks like the average was about 4.5 visits per individual. And then lastly, for the unique small group of eligible but not taking modulator therapy, we see overall less visits to start with, and then a slight trend down over the last few years, and averaging out about a little under 3 visits per year per individual in that group. So in summary, care utilization for people with CF has indeed changed over the last several years. And we reflected on the fact that this is likely due to the approval of ETI in October 2019, and then the rapid onset of the pandemic just a few months later. We know that telehealth has emerged as an important care delivery platform during the pandemic, and it's still being used, although more in adults than in children. There are differences in care patterns between the pediatric and the adult population. And there's differences also, it appears, between those on and off of modulator status and based on potentially lung health. And I'm sure there's a variety of needs and differences in care utilization based on factors we did not have data to examine today, such as social risk factors, mental health, or other complications of CF. Because of the increasing heterogeneity in the CF population, I think it's safe to say that care delivery may need to be tailored to individual needs. However, with the caveat that we need to continue to closely follow data in the registry to ensure that with any changes, care outcomes are not compromised. I want to acknowledge that none of this data that we reviewed today would be possible without people with CF and their families agreeing to have their data in the registry, so a big thank you. Also wouldn't be possible without care teams and people who enter the data, registry coordinators at our care teams. And lastly, thank you to the CF Foundation Patient Registry team for preparing this data for us to review. I'll take any questions.
Oops. Okay,
Anybody?
we do have a question. Dr. Brown, are there anticipated reasons for the persistence for less pediatric persistent swabs? Specifically, is this likely because of more telehealth visits?
Good question. Let me see if I can flip back to the data to help answer that question. Okay. Yeah, I think what that's referring to is it looks like there were 61,000 and some cultures in the cultures for children in the registry in 2019 and 48,790 in 2020. So that is about a 20% drop. And we do see that it went from 73% oral pharyngeal swabs to 87% of those are oral pharyngeal swabs. It's not clear, and if we look at 2021 and 2022, there was only a difference of about 700. So it's not clear to me which way things will go, because it does seem to have stabilized in the last year. Whether that's because of the difficulty or that OP swabs are only done in clinic and people may be coming to clinic less, I think it remains to be seen. But cultures, I think I touched on this, cultures in this population in particular are important for the initial detection of Pseudomonas so that eradication can be considered. So when there are gaps in clinic visits, I think that we are looking, and there are some groups that are looking at how do we get oral pharyngeal swabs outside of CF visits to be a little bit more innovative. There's actually a group looking at people swabbing themselves or swabbing their family members and mailing them in, or getting swabs done at the local pediatrician office. So I'm not exactly sure where the trend will go or why this continues to be the case, but I think being innovative to make the cultures happen is really critically important.
Thank you. And we do have another question. Are outcomes well maintained via telehealth visits?
I think it's hard to know, the direct impact of care on telehealth visits. In a way, they may represent a touch point and additional contacts with patients who may not otherwise come into clinic. So in a way, that could be beneficial. One drawback, of course, is that there's less objective data. There sometimes is home spirometry available, but most of the time you may not have the clinic weight, the clinic vital signs, et cetera. So I think that there are benefits and drawbacks of telehealth. It's hard to directly correlate outcomes based on that, but I think if it allows people to have an encounter with their team, touch base, check on medications and complications, and patient needs that otherwise would not have happened because they're not coming to clinic, I think that is value added. I don't think that telehealth replaces the value of in-person clinic visits, but certainly complements.
Well, I have a question actually for you,
Okay.
and just I want your input on how to handle adult care, but getting the swabs consistently. I'm concerned about the not being able to test for AFB, and because we see so much more NTM disease. So how are we going to address that?
Yeah. Good question. You guys may be aware that for AFB or non-tuberculous mycobacterial culturing, and also for fungal culturing, at most institutions, they don't accept the oral pharyngeal swabs. You have to have sputum. It can be induced sputum, or it can be a BAL from bronchoscopy. Now, certainly getting anyone, we just saw how well the population is doing on a whole, and the lack of return of the full volume of in-person clinic visits. So doing a bronchoscopy is a tough sell, I think, right now in particular. But I will say that perhaps we need to think more about induced sputum. Induced sputum is where, you guys may know, usually it's what people are doing at home all the time, but it's usually a albuterol nebulizer, hypertonic saline nebulizer, and then maybe a cappella, but it's done usually on the premises, and then the culture, if you can cough up something, is sent. So the Europeans and their standards of care suggest that an induced sputum should be performed once a year for individuals who are not otherwise able to produce sputum. So that's one thing to consider. That's not in our guidelines here, but one thing to consider. They do that regardless of how the patient is doing. But certainly if there is concern of a clinical decline and things are not adding up, they don't seem like regular bacterial exacerbations, that's completely reasonable. The other thing is sometimes, occasionally, people on ETI that don't produce sputum every day, as you know, may on occasion, get a tiny specimen at home or in the shower or after exercise. And again, I think we need to be really innovative of how and have mechanisms in place where they could get that dropped at a lab or mailed in, where they can have a high quality AFB culture done to seize the moment where they do have a culture, and we could find out more.
Well, and to speak to that, we actually have started, sending our patients home with a container and, in a bag, just in the event. If you do, please submit it, because we're the same. So there was one last question, and it is, are we just missing patients? It appears that in-person visits are up, telemed is down, but overall we are below pre-pandemic levels. With the concerns about mental health and families maybe avoiding medical care, even if not on modulators, should we be focusing more on the missing patients with in-person visits?
That's always a concern. I think yes, we don't want to lose track of people, and we know there has been some moving around that happens during the pandemic, but I think many care centers, including ours at Inova, we try to go through our patient list, and there's actually a smart report that you can run through the registry to say, this person hasn't come in the last 6 months, year, et cetera, and really run the list and reach out to folks, because I think you're right. We shouldn't assume that they're doing great and no news is good news. I think there's a lot of barriers and reasons why people may not be coming back, and they may need to. So excellent question.
Okay, well, thank you.
Okay, thank you.
Okay, and if you can give us just a minute, we're going to get our remote speakers in. There's one. Can you guys see everybody? It's hard to see what you can see up there, so.
Hi, good afternoon. My name is Maureen Carr. I am 54 years old. I have CF, and I live in Falls Church, Virginia, right outside Washington, D.C. In the last 4 years, I have made changes to my CF care, and thankfully, I haven't had to do them all alone. My CF doc, Dr. Brown, who happens to be on the stage with you today, and I have what I feel is a very collaborative relationship, which is super important to me. Since feeling so much better on Trikafta, I personally feel that quarterly CF care visits are not so necessary. But for me, 2 to 3 a year, with at least one being
Okay, I'm gonna switch it back to.
Okay.
Yep. We lose it.
Okay. Sorry about that. We had some pre-recorded things just in case, and he's going to get them back online. So, Christina, maybe you can introduce me.
There she is.
So they're back. Well, we are very excited to introduce 3 of our community speakers, Erin Dorman, Maureen Carr, and Kimberly Wingo. They're joining us remotely, as you can see. Just a little bit of background for everyone. These 3 ladies all have CF. They are also all on Trikafta and followed by an accredited CF center. They have firsthand experience with the CF care model and what it means to be someone with CF. We're going to ask you to take a moment, introduce yourself, and tell us just a little bit about you, your name, age, and location. And we're going to start with Kimberly.
Hi, my name's Kimberly Wingo, and I live in Mechanicsville, Virginia, right outside of Richmond, Virginia, and I'm 66 years old.
Thank you. Erin?
Hi, I'm Erin Dorman, and I live in Charleston, South Carolina, and I'm 31.
Thank you. And Maureen?
We saw that earlier, but Maureen Carr, and I am 54, and I live in Falls Church, Virginia, which is right outside Washington, D.C.
Great. Thank you, guys. So we're going to just ask them into questions going through about their issues with the care plan, following a care plan, and then effect on emotional wellness. So we'll also have time for questions. So if you do want to enter a question, please do that. So what I want to ask of the group, I wish I could see their faces a little better, is so before the introduction of Trikafta, can you share with us the level of challenge it was for you to manage your CF or lead a CF life, as it were, and adhering to the prescribed care model? 0 being extremely easy, 10 to being extremely difficult. And if it was a challenge, what were the challenges that you faced? You start with Erin.
Sure. It's hard to pick an exact number because it kind of varies on my life. I know when I was really young, it was hard. I was sick a lot. So I think that it really varies on my age. But as I got older, it got easier because it just became part of my routine. And that was just my daily life. So I never really thought about it much. I just did it. But if I got hospitalized, then that changed a lot for me because it would interrupt my life. So I wouldn't respond well with that. So I would say as an adult, before Trikafta, as an adult, it would probably be around a 4, probably, just going to my CF appointments because I would need to take PTO to do that. So that would kind of the only time. Other than that, my daily treatments, that I would say would be like a 1 or a 0, just because that was my routine.
Great, thank you. And Kimberly?
I would say I'm like in the middle of that between extreme, hard, and easy. I know that before Trikafta, I had a lot of exasperations in the middle and go to the hospital a lot. And I was working at that the time before Trikafta and very active, and doing therapy at nighttime specifically was just a chore to do, and sometimes I'd fall asleep in my little chair, and that's how it was before Trikafta. So there you go.
Yeah, thank you. Yeah, and airway clearance isn't so good when you're sleeping either. So, and Kimberly?
Yes.
Oh, I'm sorry, Maureen. I wrote Maureen down.
I would say that the care model before Trikafta was hard. It was difficult to make all the appointments. I would put it at, almost an 8, because typically it's not just the 4 appointments a year, the care model, but there was sick visits. Like Kimberly said, it wouldn't be unusual to be hospitalized once or twice a year. And so you're adding all those visits as well. You're in the hospital, and then you need to go like 2 weeks after you've been out of the hospital to check to make sure your PFTs are still good. Or if I was in the hospital and did some of the IVs at home, there would be an appointment to go to the doctor in the middle of that. So at some point, I think some years it could feel like you were visiting the clinic, 8 times or so, and trying to live a normal life. Like the others have said, I worked full time, I was raising a child, and you don't just, run down the street and, hop into the doctor's office and you're just gone an hour. I mean, typically for a clinic visit, the time I leave my house, the time I get back is 3 or 4 hours. And so, yeah, I did it because I think it was necessary. My health was such that it was necessary, but it was a challenge.
Thank you. After starting modulators treatment or Trikafta, how has the frequency or focus of your CF Care Center visits changed? So after starting Trikafta, how has things changed? Maureen, can we start with you?
Well, first of all, I started it at the very end of 2019, and then the pandemic hit. So, that was the biggest part that made the change happen initially, that I didn't go into clinic at all in 2020 and maybe even early 2021, just because of trying to avoid, getting COVID. And so I have a spirometry at home, so I can do that. I can do my weight. I can do everything at home, and I was able to. So that was huge. And I think I was kind of feeling so good that maybe I only went to, had 3 telehealth visits that year or so. So since then, and I will give full disclosure, my doctor is Dr. Brown, who's on the stage. She'll ask me, like, what do you think? When do you think you should come back? 3, 4 months? And I'm usually feeling so well that I'm like, yeah, I think more like 4.5 months. And, we've agreed that if I'm feeling okay, that's fine. And obviously, if I start to feel bad, then I would, call and make additional appointments. But the 4 seems a little too much given how well I feel these days.
Thank you. Erin, what about you? How have things changed after starting Trikafta?
Yeah, the telehealth has made things a lot easier, definitely. I don't live far from the hospital when I go to my appointments, but it's still very convenient. So I don't have to worry about taking time off with work. I work from home, so I just pause work and I do my telehealth appointment. So that part's really nice. In regards with the frequency of my appointments, that actually stay the same. I go every 3 months, or whether it's telehealth is twice a year, and the other times it's in person. My lung function has improved from Trikafta, but it's not amazingly improved. So I still need to go every 3 months. And that's fine with me because, again, that's part of my daily life. I've had that 31 years of life, so that's normal for me. So I don't really think much more into the frequency of it. I feel good, but that's honestly most of the time I feel good. I'm normally not hospitalized, so I don't have that experience of getting hospitalized multiple times, thankfully. So for me, that everything else hasn't changed.
And Kimberly, would you share a little bit about how things have changed for you?
Well, because I'm 66 years old, I still go to clinic 4 times a year because I just feel like that's real important. And I like every other one, a Zoom. I feel like I don't necessarily have to go in. And our clinic, thankfully, has taken really good care of us, especially over COVID. We used our grant money at the CF clinic to buy like the scales, the thermometer, blood pressure kit, and the Zephyr spirometer. So before our Zoom visit, we all do that and have all that ready to give our, the nurse calls us and we give out information. So I feel like it's just as good as going in person, but I still like that warm, fuzzy feeling like every other time to actually go there. And I've had no IV, drugs, or sick visits, really. Not that couldn't be taken over the Zoom, so I've been thankfully very healthy so far. Since 2019, I took about the same time at the end of the year, 2019, when I started taking Trikafta.
I think you are the perfect patient that illustrates all the stuff we've been talking about, actually. So, Maureen, you talked a little bit about talking with Dr. Brown and kind of shared decision making. Could the others speak to about how did you make the decisions to make adjustments, decisions about telehealth? Were you involved in that process, telehealth versus in-person, or how were those decisions made? Erin?
Well, at first it was telehealth didn't become an option until COVID. So at that time, that wasn't really, it was just more, do you have this technology? Can you do that? Because we wanted to minimize exposure going into the office. Fast forward to, and I think that was most of the time at that point. I don't recall going much into the office just to minimize exposure. But if I did, it obviously would go with a mask and not be in the waiting room long. But it definitely was more focused towards telehealth that year. And then when things went to more normal, it's now telehealth. It makes life easier for me just because I work from home. I don't have to take PTO. I don't have to figure out what time I need to go all the way down to the clinic. Not that the clinic's far, but it does take time, and it is a couple hours when I'm there. Like Maureen had mentioned, it's only like 3 to 4 hours. So you do have to plan your day around that. When it's telehealth, it's like 30 minutes and you're done. It really doesn't impact my day. And I can easily do that while I'm working. So that makes things easier. And I do have the spirometer, like Maureen mentioned. But my con with that, it is harder for me to use that. I do like the in-person PFT way better. I think I do better when someone coaches me as well. I like when people yell at me to blow harder, things like that. That motivates me more. So I do probably better when I'm in person with my PFTs for that. So that reason alone, I do like going into the clinic and seeing my people, sure. But for that, I like to get the best test results I can to prevent getting hospitalized.
That's good. You like to see your people because I'm one of your people. So thank you. Yeah. So Kimberly, decision making for you, how was that handled? Was that something you decided, or did you with your provider discuss this, or how was it handled for you?
Well, when Zoom first started, even though I was part of the CFLN to get Zoom going at our clinic, I was still leery about that. I just didn't think that was going to work, but it does. It really did. And I think most of us are used to Zoom now and comfortable with it. And that's okay. There was something else I was going to say, but I forgot what it was. Go ahead. What was part of the other question?
It was just about decision making, but that's okay.
Oh, but my physician, CF physician, has mentioned his own self that if you want to come in, for 5 months or instead every 3 or 4 months, he's probably all in on it. It would be fine like 3 times a year. if I'm well and not having any problems at all. But because I'm 66, well, and I just feel like I better really do the straight and narrow thing. Because it's that, and we don't know how long Trikafta is going to last, because the two other drugs that they had, they didn't last as long. And so far, so good. I mean, I guess it's like, 3 years now? Trikafta is really holding up. But like most medicines, they're really good at the beginning, and then we don't know. So I just want to keep things going the same, just in case.
Well, we do too. Thank you. There's another question that I want to direct toward the panel. So if you guys could just hang on a sec, because it talks more about pediatric visits. So what considerations and concerns are there for decreasing visits in pediatrics? Children are often not as good at communicating symptoms, even with parents, and especially when they are school-aged, and spend less time with caregivers. Are there more concerns for missed exacerbations or clinical changes?
So that's a great question. This is Rebecca Brown. I can speak to that. The committee, as we've discussed the new model of care and thought through what recommendations we would make, early on we realized that it's not going to be a one-size-fit-all throughout the lifespan. And so there are some age groups where we think continuing the current model of care for frequent visits would probably be best. In children, we're still deciding how, up to what age, but in general, children, the younger children are going to be part of that for those very reasons. The other thing that we thought was important is that's when you're establishing your relationship with your CF care team, you're learning your own self-efficacy and self-advocacy at that age. Children are learning about CF and kind of getting into the routines. And so there's just a lot of important aspects of CF care that are even outside of just lung function that we develop during those early years. We had the same conversations around other transition points. For example, when you transition from the pediatric to the adult world, that's probably another time where continuing a regular frequency of visits to establish that care and develop those relationships would be important. And so those are all aspects of the new model of care that are being discussed. And certainly, definitely fill out that survey to give us more information about what people are thinking, because these are definitely important discussions as we move forward with this process.
Thank you.
Back to the community panel, I think we're going to change gears a little bit and focus on emotional wellness. As you began your modulator treatment or Trikafta treatment and noticed physical improvements, did you find it easier to adjust your treatment plan? Erin, do you want to speak to that?
Sure. So my frequency and what I do for care is still exactly the same. And that's for numerous reasons, but most primarily I value my safety and security and my health. And for me, I don't want to risk messing anything up. I've been doing well. And so for me, if it's not broken, why fix it? So I like to stick with what I know and stick with my routines. And my lung function has improved with Trikafta. It's not the highest it's ever been in my whole life, but it's still good. I know it can be higher for other people. So for me, I'm in my 50s percentage wise. So for me, I still go every 3 months. If it was higher than that, maybe I would consider changing things. But for me, it's not that high. It's much higher than it was, but in a whole global scale, I still would like to go every 3 months just to make sure everything's staying the same. And in regards with changing, like how I've been feeling, a lot changed for me. I remember the first time when I realized I couldn't hear myself breathing anymore. I've always, out of 28 years at that time, always heard myself breathing. And when I realized I couldn't hear myself breathe anymore, that I'm still adjusting with, actually. I'm still not fully accepting that. Like, there's times where I make myself take a deep breath so that I can hear myself breathing. And that's kind of like a mental check-in for me of like, okay, you're still breathing, even though I know logically I'm still breathing, but it's just like a security blanket for me. So that has really thrown me off with that. It's a good thing, I know that, but mentally and emotionally, I like to check in on that. I think that's probably my biggest takeaway on that. And honestly, I didn't even know people couldn't hear themselves breathing until my friend was like, oh, you used to be able to hear yourself breathe? And I was like, yeah, you couldn't? So just my worldview has changed a lot on that regarding. But that's probably my biggest thing that I notice of not being able to hear myself breathe. That still mentally jars me.
Yeah, it's interesting.
Thank you, Erin. Kimberly, as you began Trikafta treatment and noticed physical improvements, did you find it easier to make adjustments to your treatment plan? And how did you do that?
Well, I'm like Maureen, that I pretty much keeping the same routine as before, but I'm very active. So if I come home really late and didn't get that last therapy in, I take sleepover therapy now. I mean, it's rare. I don't do that all the time. I'm a good girl. I take sleepover therapy when push comes to shove and it's late at night and I've been out all day and I'm pooped. So everything else is pretty much the same.
Thank you. And Maureen, how about you?
Like the other, well, I shouldn't say like others, I feel a lot better on Trikafta. My pulmonary function tests have gone way up. I breathe better, the same thing. I can't hear myself breathe anymore. And so I kind of stay on the same track in terms of treatments. And I think for the same reason, I'm a little bit older, so I've had some damage to my lungs, from the past, and I've had some bacteria problems with what I've grown. And so I'd like to keep on the same treatment schedule kind of for the same reason. I want to keep my lungs as healthy as possible for as long as possible. So not only do I love the bump up I got from Trikafta, but I'd like to stay there and I'd like to stay out of the hospital. So continuing, doctor's visits and taking treatments is really important. But I have to say, it is a burden, meaning it is very time consuming. It's what I've always known, but it's not like you love spending time doing airway clearance and taking your meds and stuff like that. So again, I feel like I have a really good collaborative relationship with Dr. Brown. And I know that there was the PROMISE study, I believe that's what it was called, that people stopped either their hypertonic saline or their Pulmozyme and, did just as well. But for me, I think it was only a 6-week study. And that wasn't long enough for me to feel like if I did one of those, that things would that my lungs would stay the same. So Dr. Brown and I had an in-depth conversation about that. And I think she understands that I'm a little risk averse and knows my past history with what's been going on with my lungs and understands where I'm coming from and kind of feels the same. But we had an interesting discussion and rather than dropping either Pulmozyme or 7% of the saline or dropping one of my treatment times, I just use often like 1/2 to 3/4 of the ampules of albuterol and Caistin. So I'm still doing my treatment twice a day. It's just the time burden has gone down a little bit. And I didn't do that in a vacuum on my own. I mean, I did that with the discussion that if I started to feel not well, I would go right back to my normal procedure. And also we would check in at my next appointment and see if my lung function was stable. And if it was, then that would know that, that was okay to do that, to dial down a little bit on my treatment. And that thus far has worked really well for me. And I think I really like having a partnership with my doctor because I like making the decisions. I like having input, but I like also being able to decide based on how I feel, because, I know how I feel. I know how my lungs are feeling, and I'm the only one that really knows how that is.
Thank you for that. It sounds like you all have been relatively stable, not had any exacerbations or issues since starting Trikafta. But if you did experience a decline or had to, possibly get IV antibiotics or hospitalization, do you expect that would affect your emotional wellness? And how would you deal with that, do you think? Maureen, can you speak to that?
Yes, absolutely. It would affect my mental state. My mental state has been much better since feeling healthier. I mean, you can imagine that when you're not feeling well, when know that you have a disease that's progressive and is going to, slowly decline. And when you've been seeing that, when you've been hospitalized, it does take a toll on your mental health. And so with Trikafta and with feeling well, my mental health has improved. But the longer it goes without having an exacerbation and being hospitalized or on IVs, the harder it's going to be maybe that won't happen, but when it happens, I think that's going to be mentally very challenging. Because at the moment, when you have 4 straight years, it feels like, wow, this is, one step below a cure.
Thank you. And Kimberly, what are your thoughts on that?
Well, I'm good at having a little pity party, but I can get over it. And to be having really bad exasperation would be very devastating for me, because before COVID, we had primo rooms in the hospital. There was a brand new part of the hospital. They trained all the nurses for CF people, because we would take up maybe a third of it. And we also had students that were learning PFTs. Now we started out on us, beating us, giving us therapy. So we'd get that, hand therapy 3 times a day, and I would take my vest. I would do that as well. But now all that's gone, because now there's not as many CF people going to the hospital. So they moved the entire all-sit clinic, CF adults now go into this really old place in the hospital. No more hand therapy. I mean, it's like, why go? So if I do get sick, I'll probably stay home. And my husband can access my port if needed. So I'll be good at home.
Yeah, that is tough. Erin, what about you?
Yeah, I have a unique experience where I've been fortunate where I don't get hospitalized often. Even before Trikafta, when I'm not doing well, the most I would get hospitalized was once a year. But it was really normal for me to go years at a time, not being hospitalized. So I haven't been hospitalized since 2017. And I started Trikafta, I think 2018, 2019, somewhere around there. So this is definitely my longest gap of not being hospitalized, but I am used to going several years not being hospitalized. I have gone where it's been once a year as well, but that's when I'm not doing that great. So for me, I'm used to going long gaps. So that's kind of more of my norm on that side. So for me, I view just getting hospitalized as, when I'm viewing it in a healthy way, as a tune-up. It's required. If you want your car to go, it needs to get a tune-up. So if I want to keep breathing and living, I need a tune-up from time to time. So that's kind of how I view it. Now I'll get frustrated if I'm in the hospital for a long time. That's different. But as a hospitalization overall, I just view it as what we need to do, or what I need to do to, get back to being on the track of being able to drive on the road again, being healthy again, so that I can go back to my quality of life. I think the part that I hate most about hospitalizations is it does pause my life. It's a huge burden in regards with that, but I also know it's insanely required for me to get back to my life. and to live my life as long as I can. So overall, I do expect at some point to be hospitalized. I don't think, that will never not happen. So whenever it does, because I'm sure it will just be my tune-up time.
Well, thank you. That is, I asked that question because I had a patient that did as well as you all have, but then ended up with the lower lung function exacerbation and had to start IV antibiotics, and he got really, really depressed about it because his thinking was, I'm cured now and that won't happen again. So I, as a provider, had failed to think of that, but the emotional impact was pretty significant. So thank you for sharing that. We do have some other questions from the audience. One thing they wanted to ask the panel, what genetic mutations do you have? We can start with Maureen.
I have 2 of the typical Delta 508.
And Kimberly, did you?
I got the real thing, honey. That's the same thing, 508 double copy.
And Aaron, what about you?
Same. I'm a double copy of the 508.
Thank you. Okay, we have a question. Go ahead.
Yes, I don't know if you, in the Zoom call you can see who this is. So I'm watching her voice right now, but I took care of Kimberly for 10 years and have been her friend for 7 years after that. And I've come here to, number one, make sure that she did not lie about her age because I'm 1 week older than her. Number 2, teach everybody in the room to say exasperations rather than exacerbations. But number 3, my question, Kim, 66 years old, you've always been older than the mean predicted survival rate with CF patients. At what age did you decide that you need to do what people are telling you to do, and you get to decide which ones are best for you?
Well, I've always felt that you are your best advocate, yourself. So when I talked to back then it was one CF clinic, pediatrics and adults together. And I was in my 20s, I decided, no, I don't want to take the same antibiotic over and over and over again. I said, because you need to shock those bugs, and I was like, that's what started me in my young 20s, taking over a discussion with my doctor rather than just listening and doing. I think we know how we feel and we have ideas, and it's okay if the doctor says, no, we really need to go this other route. Why? As adults, we need to know why. And I'm good with it. And I think just growing up as a little kid, my mother raised me to take care of my own things. My dad made a mist tent, had a air compressor in the basement right under their bedroom. It's horrible. And it was propylene glycol. There was nothing back in the 60s for people with CF. And in the morning before going to school, it was my job to wipe those plastic curtains dry and roll it up and all that, and then get dressed and catch the bus. I lived out in the country. And so I was always, my parents helped with that to get me more independence and do my thing and take care of myself a lot.
Thank you. We do have a couple other questions for the panel. For the panelists, would it be beneficial for care centers to offer extended hours and weekend appointments? Since time constraints are a recurrent theme, would it be helpful to see the medical provider and respiratory therapy only during the visit and the rest of the team on a telehealth visit? Thoughts on that from providers?
I mean, I certainly know of some places that do have extended hours or weekend visits. I think from a logistical standpoint, every place is different in how well they can support that type of practice. We have had times where we had late night clinics And over time, it just wasn't supported by nursing support anymore, so we had to stop them. And so I think, yes, to be more accessible to patients, that may be something to consider, but each individual institution is going to have to figure that out individually.
And I think for our center, we've discussed too asynchronous visits and what do we really need to do at a visit, and but we kind of step away from the care model in that sense too. So what is the right answer? I guess that's why we're having the discussion too. Any other thoughts, Dr. Whitney Brown, on that? Sure.
I think it's reasonable to try to meet individual patient needs and priorities in terms of not seeing every team member in person at every visit and following up via telehealth with a particular team member if there's an issue, or skipping that visit for the whole complement of the team if it's not necessary. The guidelines say at least once a year to see every member of the care team, and so I think that's quite doable, and it could be in person or asynchronous. I think that's reasonable. We found some benefit of doing synchronous televisits where we can actually all get on the visit at the same time. That's one advantage, that it will save time because everybody's on the time together. So if 40-minute visit, we can have a group conversation and everyone chime in their relevant section. So that can be, I think we can be very creative with how we deliver care. And I think certainly considering people's individual needs and preferences, the extended hours and weekend, I think right now may be a tough sell. I would love that as a patient myself, but we do know that the care teams have been under a tremendous amount of stress and burnout and have their own families. So I think it's a balance, and we do want to compromise, but telehealth might be a good compromise in some situations to allow people to work from home and miss less work, but certainly maybe as time goes on and people, the health system is staffed up better, we could consider those alternative times.
And just to quickly add to that, as we tailor clinic appointments to meet patient needs, this is where pre-visit planning and agenda setting is so critical. And so if you start off with a good pre-visit plan and agenda setting in conjunction with the patients and families, then that can help figure out who is necessary for that visit, what could be asynchronous, what could be postponed to the next appointment, and go from there.
We have another question on the app. What characteristics, disease, sociodemographic, economic, et cetera, should be considered when considering customizing a care plan for a patient? How do you identify good candidates? Thoughts?
Yeah, so how we've been addressing this as a committee is thinking through what would be considered a stable state of health. And that includes not only lung function and nutritional status, but also, from a mental health standpoint, oftentimes we do the screening for mental health, we identify depression, and we may be the only touch point for that patient until they can get into psychiatric support somewhere else. As we know, psychiatric support is limited across the U.S. right now. And so in those settings, maintaining that a good frequency of visits may allow those extra touch points to keep somebody in a stable state of health. We also will consider stability to include socioeconomic stability, because again, we have a social worker in our clinic, and how often outside of a CF clinic can you really get social work support? And we definitely have families who need that support. And so we're working really hard to help define what would be considered a stable state of health that includes all those extra qualifications in order to determine which patients would be ideal patients to step back step back appointments versus maintaining the current model of care from an appointment standpoint.
I'll just put a plug for the survey that the code is up there. You can actually, there's a question that says, gives these scenarios and says, do you want to decrease the frequency, maintain the frequency, or increase the frequency of how often the patient needs to be seen based on different factors? Because we know, like during pregnancy or other things going on in life, that's not the time to be seen less, probably more. So we're trying to create a framework that could help guide sort of a shared conversation with patients and families to make those decisions.
Well, that segues into the next question very well. If you are considering weaning other support medications like pancreatic enzyme replacement therapy or lung therapies, would you actually consider more frequent visits than every 3 months?
So potentially, and certainly one of the things that we had put in for stability was also stable therapies. And so if we are considering either changing in therapies, for our pediatric patients as they gain weight, their medication doses go up. And so we would not decrease the frequency of visits during that period. But then also if we are making any changes to de-escalate care in some way, whether that's decrease the aerosolized treatments or pancreatic enzyme replacement therapy, decreasing the dose, we would definitely want to at least maintain the same number of visits or potentially increase the visits. And again, that's where your input on the survey would help us determine which one we should probably recommend.
And do you think appropriate, I was going to ask an appropriate opportunity for a televisit, but I guess that would depend on what your change had been. So,
Exactly.
Any other questions? Thank you.
Just a quick open-ended question to the community members. Is there anything that you want to add in addition to what you've already shared? Is there anything specific you want the audience to know from your journey, from your perspective?
Want to start with Kimberly?
Kimberly.
Well, when you're talking about PFTs and, going to clinic or anyway, one of those questions. At VCU, our clinic can put an order in the hospital for a PFT or for a blood panel or for any, one of those routine tests that we have to do. You don't have to just come to clinic to do it. So, and that the order will last for like a month before it kind of like ages out. And so you can pick your own time. And there's places like all over Richmond, go to the one that's closer to you. You don't have to, so if you want to telehealth, and you want a PFT, we just don't, you don't have to do it right then and there. You've got a month to do it at your leisure, at what time you grab, like maybe during your lunchtime. So I just want to mention that.
Thank you. It makes it convenient for sure. Erin, what about you? Is there anything else that you'd like to add to the conversation? It doesn't necessarily have to be elaborating on anything that you've said, but regarding the care model or your experience with changing, making modifications, or your emotional wellness.
Sure. I know we didn't say this, but I think one of the factors that's really important is looking at when someone was diagnosed with cystic fibrosis. Because I was diagnosed only a couple months old, so I grew up around this. This has always been my norm. My big adjustment really was when the Trikafta came, where I started to really improve in not just lung function, a lot of other areas in life. But I think it really depends on what your norm is. And also, I'm really fortunate I had good resources throughout my whole life. I have a parent that's in the CF care team. So I really grew up around this is normal and these are things that you do. So I think that makes a really big important about my care and how I view it. And regarding with when I have appointments, I wouldn't want to do on the weekends because that's my freedom. Like that's when I get to just have fun or do whatever I need to do. I like having appointments on the weekday. Yes, it impacts my job, but that's what PTO is for. And I know 3 months in advance when that is. So I arrange that and I plan for that. So I would rather that than, I feel like a burden for me would be on a weekend because that's when I have fun and I have my freedom. Well, I think the work week for me is very structured. So I can put that in there very well. And being a parent of someone on the CF team, I'm used to them, getting home late, but I wouldn't want them to stay later more than they needed to because they have their own lives. And I would have wanted to spend time with my parent. So I wouldn't want my care providers to be longer than they needed to from their family because they're also, they need to have good quality of life to also help me have good quality of life.
Good point. Thank you.
True. And Maureen, is there any additional information you want to add?
Sure. I want to hark back to, because somebody asked a question about when we were showing one of the slides was that there's like a 35% gap help me out, 35% gap in people not being seen under a CF clinic care. And somebody asked why that might be. And the data that is not the why, but I went for a couple of years not being seen at a CF care clinic. And just here's one idea of why is because the adult CF center was in Johns Hopkins, was closest to me. And that is an hour if there's no traffic away. But if there's traffic, that can be up to 2 hours away. And so that meant, if I had gone up there, it would take almost a whole day that you needed to take off to basically get up there for the clinic appointment. But more importantly, when I was hospitalized, it was my husband wouldn't have been able to come visit and my son wouldn't have been able to come visit on the evenings. It would have been, they would come visit probably once on the weekend. It was just too far away. And I'm sure that, others probably experienced that. And I needed my support system. It was more important to me, like when I was in the hospital, for me to have my support system than it was to go to the CF clinic at that time. And I'm fortunate because now there is one super close. It's, like 3 miles from me. So I'm lucky in that sense. So that's how I came back to being seen in a CF clinic. But what else? There was something else. Let me think that comes up. And then also heading back, we also at Inova, they do the same thing where they can put in for the sputum cultures, they can put in a whole year, kind of like a standing order. And so for those of us that can't always on command cough up anything and are not dying to have the throat swab done, I don't find that enjoyable. So somebody else mentioned, so you can do it whenever it happens. And again, if it's after you've gone out running or I've taken a yoga class, then I can do those cultures at my own time frame when it actually happens. And I think that that's been useful too, as something that's a little different.
Very good point. Thank you.
Do we have any more questions?
I don't think so. I think that's it for questions. Mm-hmm.
Well, we want to thank all of you and especially our panelists and our community members for sharing this time with us. We hope that you all in the audience have learned some valuable information about this open discussion and can take something back with you to your care center and your team. So thanks again for spending some time with us and enjoy the rest of the conference.